I guess all I can say is, wow, how far things have come since I was in medical school. I think it was like 25 years ago. And I'm one of those medical students who probably did not spend nearly enough time on genetic medicine, so I leaned over to Jacqueline when the introduction was made, and I said, they're still not spending much time on that? And but wow, there's so much to learn. Even in my own company, so my name is Martin Zagari. I head up actually the health economics and health outcomes department at Amgen. And unlike Jacqueline and Clara, I'm just an economist, basically, right? I'm not an expert in personalized or precision medicine. And so when Dr. Erskine called me, I tried my best to get out of doing this talk, actually. Because I said I'm not really an expert. I said I could potentially put, kind of more of an economic, delivery system spin on precision medicine. And then she surprised me by saying, wow, that sounds really good. So here I am, and I'm going to come at this from the perspective of an economist, of a health economist and someone who looks at the delivery of care. But I am glad because I think there is some concordance. I saw in both presentations there were some key words there. I think there were the words environment, right? There were words lifestyle, right? And actually I believe that it's going to be very difficult to have really, really good precision medicine unless we have precision healthcare delivery, unless we have a healthcare delivery system and a regulatory system and all the other kind of trappings of delivering medicine in a modern society. If that system must step up to the plate to match the amazing advances that's going on in precision medicine. So I'm going to look basically very briefly at 4 areas that I've had, sort of direct interaction with, where I've sort of taken a step back in preparing for this talk and said, where is our health system sort of running behind, right? Where potentially is the health system going to fail, right? This run towards precision medicine that has so much promise. And so I came up with 4 areas. And so my first area is actually a regulatory construct on a product that Amgen developed. And this product is called Vectibix, right? And in this case, it's the difficulty of marrying diagnostic testing, in this case genetic testing, to an actual therapy that comes onto the market. And so, here's the example. We had a product, Vectibix. It's kind of a poster child for precision medicine, but I would call it a poster child for slow motion precision medicine. Because we actually got this therapy approved in 2006, and it was approved for third-line metastatic colorectal cancer. And even at that time, we actually were beginning to see data from the genetic testing that we were doing that there was a differential response in patients based on their genetic profile. And in the case of this drug, people who had the wild type of a gene called KRAS did much better on this product than people who had a mutant type of the KRAS gene. And so in 2009, after, again, you see the pattern here is a multi-year delay, right? We actually got that information incorporated, right, into the label, right, along with a biomarker test. But, think about it. We were seeing this data in 2005, right? This wasn't like a sort of a general it wasn't a general doing better. I mean, this was, if you had mutant KRAS, you did not respond to this drug, right? And if you had the wild type, upwards of 40% responded, right? And yet it took a good 3 years to get this incorporated in the label. But that's not all, actually. Further study revealed that it wasn't just the KRAS gene that could be essentially mutated and attenuate the response. It was also a gene called NRAS, right? And so it turned out that people who had both wild-type KRAS and wild-type NRAS mutations did much, much better. So I'm withholding actually showing you the data because I just think it's amazing, and here's what's amazing, how this type of testing can turn a marginal drug, dare I say it. You'll rarely hear a person who works for a pharma company call one of their drugs marginal. But I am tonight. I'm calling this a marginal drug as of 2006 because the hazard ratio when this drug was brought to market was 0.955, right? Not very impressive, right, for a response. So just by introducing the wild type test, the hazard ratio for a response dropped to 0.8. And by introducing both tests, the wild type NRAS and KRAS test, the hazard ratio dropped to 0.72. And just to give you, an idea of what that means, when the drug was marginal, it basically was a median overall survival improvement of 1 or 2 months, right? With the KRAS test, that moved out to 5 or 6 months. And with both tests, it moved beyond 6 months to 7 or 8 months. And the reason I show this example is, this is not a judgment call when we saw this data. And yet it has taken 10 years, right, to get this information incorporated into a drug label so that we can actually have a communication about it with physicians. 10 years, right? So that's some of what we're facing. All right, example, and I'll just show you here. This is the economics. I have to put a flash of this up because I am an economist. Right? And you can see that, I don't know, those of you who know anything about cost per quality know that the lower number is better. That means you're paying less for a quality-adjusted life here. And as you can see, the difference even between KRAS and wild-type RAS is a substantial difference. And this drug wasn't even in the ballpark of being economically viable before we were doing the RAS testing. All right, example number 2. I've borrowed these slides shamelessly from the University of Michigan, right? Another esteemed organization. Mark Fendrick runs an institute there called the Value-Based Insurance Design Institute. It is, I think, a critical institute to get people to think about how we can have precision healthcare, precision, basically, insurance design, right? And basically, most of our insurance now is focused on the price, the cost, the volume of care, right? And we would much rather, I think, have insurance that focuses on how well that care is matched to us. I think both of the speakers before me said we've got many opportunities to try to match care better to patients, right? And I think this is critically important because healthcare insurance right now does a very poor job at basically saying, wow, for high-value services that have a strong evidence base and enhanced clinical outcomes and better efficacy, we need to encourage patients to do that. And for lower-value services with a weaker evidence base, we need to discourage that. But think about how your insurance is designed. Your copays are the same, right? No matter if you basically have a high need for a drug or a low need for a drug. Your copays are the same if you basically have failed 2 or 3 prior therapies, right? Or if you're basically trying your first therapy. So the whole push behind value-based insurance is we need to design our insurance to basically motivate behaviors in patients that enhance their health. So for example, if you're a patient who has failed 2 prior therapies and you're coming up on, wow, failed these therapies, I'm still not controlled, you come up on the 3rd therapy, right? Why should you necessarily essentially penalize that patient with the same copay as someone who hasn't even tried the other 2, right? So this is the idea. We want people to step through therapies. Let's design insurance that actually encourages that. So in effect, what we need to do is we need to basically recognize that services are very different. We've already heard that. And we need to design insurance that basically begins to differentiate. Now, there are many barriers to this. And I've talked to a lot of insurers about this. Many of these barriers are, in fact, regulatory in nature. So essentially, it is illegal for insurance companies to discriminate in these sorts of ways. But I think, as UCLA and as a public health institution, I think efficacy, equity, timeliness all demand that I think we think differently about insurance. Budget impact. This is an interesting graph because we actually had a health economist right here locally in Los Angeles. His name is Michael Broder. He works for the Pharmacoeconomic Institute. And we ask a simple question. We ask the question, how good are we at predicting the uptake of medicines? Because when you think about it, we should have a robust dialogue with payers and physicians. And when we bring a new medicine, it's well studied. So we should be able to predict pretty well how a medicine is going to be taken up. This study shows that we're actually not very good at that, right? And so this chart here, this basically is the multiplier of how wrong we were about uptake, right? And so the higher those bars are, the more the system actually grossly overestimated the uptake. And so when you go all the way to the end there, you see essentially PCSK9s, of which my company has one. You see some Hep C treatments here. You see Zagari. And essentially what happened is when the system analyzed what the demand for these drugs would be, they grossly overestimated the demand. The insurers clamped down such that even the patients who are now deserving are not able to get access to these therapies. And so essentially, we are having a difficult time in our system differentiating between the patients who truly need drugs, right, and then the patients who really shouldn't be on them, right? And the right panel just shows the dollar version, and you can see, we need to get much better at this. Our company needs to have a dialogue with insurers, and we should be able to sit down with them, and we should both be incentivized the same way to get the right patients on the right medicines at the right time. Right now, the incentives are opposite. Every single mechanism in place in insurers is to keep them off the product, and everything we do is to try to get them on. And that tension results in an uptake curve like this. And finally, I'm going to talk a little bit about patient selection and value, right? I think we have to be much better, I think, at determining what's the value of a product or a therapy or a test or a diagnostic when it gets into a certain type of patient. And so I got just one more slide here. So these are health economic analyses that have been performed on the same drug using essentially the same model that have come to extremely different economic results. And I show this slide because everything in the top left corner is essentially a health economic analysis that ruled, in this case, they're lipid-lowering drugs, PCSK9s, that basically determined that they are very cost ineffective. Everything in the lower right panel are publications that suggested that they are very cost effective. And there's only one main difference between these studies, right? These studies basically presuppose that patients who got these products would be having about 3 events per year, 3 cardiac events. These studies over here presuppose that patients were selected so that they would be having 10 or 12 events a year. So I show this because there's a lot of argument out there about value, about economics, about cost, but who you pick for the drug is so important when it comes to affordability, when it comes to essentially the value of the product. So I throw these things out there. If we're going to have a dialogue about precision medicine and personalized medicine, I think we need precision insurance. I think we need to be much better at basically deciding who these products go into. And I think we need mechanisms to basically make sure the right people get the right products at the right time. Thank you very much.